Tonight, I want to introduce you to Dave. He's one of my co-conspirators here. We do a lot of recordings and record different people kind of coming out with new data to support kind of the stuff that we believe in. And we are so honored to have again with us Dr. Paul Marik, who is
legendary.
legendary, and paving the path to something that's really near and dear to my heart because I have so many patients calling my practice with new diagnoses of cancers. And he is really kind of who I'm following, and he's been a legend in kind of showing what some of these repurposed drugs can do to help fight cancer. So Paul, go ahead and give us a little bit information about what you've been doing and what you've been seeing.
Well, thank you, Sarah. Thanks for having me back again. And so, obviously this is a dynamic process. It evolves every day as we're learning, as the science evolves. And, we need to be clear that this is not just coming out of thin air. We follow the science closely, and this is supported by an enormous body of scientific evidence. But what has become clear is our understanding of the process has evolved. So, when I started, we had a list of, 35 repurposed drugs, but we have now a much better understanding of how they work together, how to group them, which ones to use together, which ones to use for different cancers. And so that gives a much more logical and scientific approach. So to actually tell you what happened is really kind of interesting. So for the last 2 years, I've been reading papers, maybe 2,000 papers on repurposed drugs, and came out with my first book and then the second book, in which I listed 35 drugs. But I had listed them, in an order I thought made sense, but it was very much based on just common sense rather than a way to scientifically validate it. And then my co-conspirator, Justice Hope, said, you know what we should do? Why don't we ask artificial intelligence, AI, what AI thinks and how we should rank these drugs? And so then we started ranking the drugs according to AI. At first, I was a little bit suspicious because I thought AI would be controlled by Big Pharma and the enemy, but soon to discover that the information it provided was remarkably accurate and supported by scientific references and made an enormous amount of sense. So the remarkable thing is, and so maybe this is why we know it's valid, is that AI's list of drugs and our list of drugs were almost the same. Wow. So what took me 2 years to do, AI did in 5 minutes. And since we've now understand how AI works better and we know how to ask it better questions, it's become more refined. And so basically, to a large extent, chemotherapy is shotgun therapy. You give an agent which damages chromosomes. It's not specific. While there are targeted therapies, it's not specific, acts on one specific pathway, and it does a lot of damage. And probably the most absurd thing about chemotherapy is it damages the immune system. It damages your T cells and your lymphocytes and your B cells, which are the cells you most need when you have cancer. So you need to have your immune system fighting the cancer. But what does chemotherapy do? It knocks out those very cells that you need to fight cancer. So it actually makes no sense. It's a completely meaningless, senseless kind of therapy. So the way we've kind of looked at this now is that cancer has a number of components you need to deal with. The first is the metabolic dysfunction. So what we do know, going back to 1924 and Otto Warburg, is the cancer cell is metabolically different. And all cancer cells are metabolically different. Doesn't matter what an oncologist says. That is just an absolute truth and a fact. So the first line of therapy is to use drugs that target those metabolic pathways. And so we know which drugs do that, and we know which pathways they target. Pathways such as what's called HIF1 or c-MYC or NF-kappa B. These are specific biochemical pathways. These aren't random pathways. Hexokinase 2, these are specific pathways of the cancer cell. So the first line of therapy is to target those biochemical pathways which the cancer cell relies upon, because cancer cells need glucose. They're highly glucose dependent. This is the Warburg effect. They cannot undergo oxidative metabolism. So the metabolism of the cancer cell has changed. So we, as clinicians, can use this to our therapeutic benefit by targeting those pathways which the cancer cell uses. It's pretty simple because they are different from normal cells. The pathways are different, and it just so happens some of the most powerful pathways are affected by EGCG, which is green tea, and curcumin. Isn't that astonishing?
Right.
Beautiful.
The most powerful pathways that interfere with cancer metabolism is these two.
Wow.
So the first approach is to deal with the altered metabolism. And then obviously together with that is diet. I mean, most oncologists are completely clueless, but we know these cells are dependent on glucose. So you need to limit the amount of glucose you take in. Now, obviously, we would suggest a ketogenic diet, but for some patients, it's not that easy to adopt a strict glucogenic diet, ketogenic diet. But you know what? You need to reduce your intake of glucose. Glucose generally is a cellular toxin. It causes glucose and carbohydrate addiction. So patients should just cut out processed food and glucose, because if they think about what they're doing, they're feeding the cancer cell with the sodas and carbohydrates that they're eating. They're feeding the cancer cell. So if you use metabolic therapies, which we've mentioned, together with dietary manipulation and ketosis, that's really the first pronged approach to dealing with cancer. The second is something called a cancer stem cell. And it seems like oncologists have no idea about a cancer stem cell because they don't deal with it. And so the cancer stem cell is the cell that gives rise to the cancer. And so the astonishing thing is that chemotherapy does not kill the stem cell. In fact, many chemotherapeutic drugs actually promote the growth of stem cells. So what you're doing is you're taking away the rapidly dividing cells, but the stem cells, which ultimately give rise to the cancer, you're leaving alone. And these then give rise to metastatic spread. It is so completely and utterly stupid and inconceivable that an oncologist can ignore a cancer stem cell, because you cannot, we don't like to use the word cure, but you cannot induce a remission unless you deal with the stem cell. You have to deal with the stem cell. And we know what the pathways are. Again, this is all biochemistry. It's well published. We know the pathways that are involved with the cancer stem cell. And so guess what drug is the most effective drug for dealing with, and I hate to say it and you're laughing, the cancer stem cell.
Where's the horse taste?
Here it comes. It's this word that, you get banned.
And you see, you don't have to ask me. You can go to AI, and AI is not going to lie to you.
Sure.
It's the eye drug. The
Yeah.
eye drug is the most effective drug in dealing with cancer stem cells. And then you combine that with, the other antiparasitic drug, mebendazole. They're very potent together. And then you add vitamin D. So those 5 drugs form the basic components of our basic therapy. Green
including
tea,
the ECGC and the curcumin.
yeah, the ECGC, the curcumin, the ivermectin, the mebendazole, and vitamin D. Those 5 serve the basic or the cornerstone of all of our treatment protocols. And then there are other things that you can add, but we believe those are at this point in time, the 5 major drugs or agents patients need to take. And when we talk about ivermectin, we're not talking about doses, gazillion milligrams. We're talking about 0.3 initially to 0.6 milligrams per kilogram. And when we talk about mebendazole, 200 milligrams. So these are reasonable doses, because there are people out there recommending completely ridiculous doses. The other thing that I need to say is that there's this notion out there that is perpetuated by complete goofheads. I think they're goofheads or nutcases, or I don't know what you want to call them, who believe that because ivermectin and mebendazole are active against cancer, and because ivermectin and mebendazole are parasitic drugs, that cancer is a parasitic disease.
Thank you.
So these people are complete and utter nutcases. Because as I've explained to you, ivermectin works via specific pathways.
Right.
This is well reported in the medical literature. This is not made up. And these pathways have nothing to do with the way ivermectin kills parasites. So it's just one of those remarkable things about ivermectin. It's this multi-potent drug that acts via multiple modalities. One of the ways it doesn't kill parasites, but it's not the way it kills cancer cells. And so there is this ridiculous notion that patients should go on a parasite cleanse. So what you need to do prevent cancer or treat cancer is go on a parasite cleanse. It's complete and utter BS. And we need to stop this nonsense from being further perpetuated. Ivermectin acts via specific biochemical pathways which interfere with the cancer stem cell survival. It's as simple as that.
Yeah.
And then obviously the other things that are important is the immunity. It's really important. I mean, cell surveillance and T-cell immunity is really important. That's how we get rid of cancers, is we have our T killer cells, our lymphocytes are getting rid of cancer. And to have therapy which knocks out your immune system makes absolutely no sense. It just so happens that curcumin and green tea actually have very important effects on your tumor microenvironment to improve your T cells and to suppress your myeloid depressor cells and your T regulatory cells. So these drugs have multiple modes of action. So it's a beautiful orchestra that's played together with all of these drugs working together, working on the stem cell, the specific biochemistry of the cancer cell, working on the tumor microenvironment, tumor pH, the tumor immunological status. It makes no sense if you think about it. The way we get rid of cancer cells is our immune system. Why would you want to whack out our immune system? And then you have things like angiogenesis, which promotes metastases. So It just so happens that all of these drugs act on all of these pathways to improve the outcome of cancer.
Mhm.
I think
What,
the chemo answer is because $250,000 to $500,000 to extend somebody's life, maybe for months.
yeah, so the data shows that, and this is published data in oncology, that the newer FDA-approved drugs, approved by the FDA, costing on average over $100,000, on average prolong life 2 months.
And they make you so sick. So it's not that they're prolonging your life and you feel really good.
Destroying your immune system.
Yeah.
Exactly. What they're doing is they're prolonging your suffering, because they don't talk about
Yeah.
quality adjusted life. They're prolonging your suffering by 2 months at enormous expense. And so that's the problem. But it's because the FDA was in bed with Big Pharma. Maybe this will change now, but obviously money speaks. And, vitamin D is so important. Vitamin D is really, has multiple modes of action. That's why it's on number 5 in the list. It has multiple modes of action in cancer, predominantly by improving T cell and lymphocyte function. So it improves the immune system. So I just replenished my yearly supply of vitamin D.
What's your goal?
It cost me $14.
$14.
So
I'm still trying to
that tells you why they are so scared.
Sure.
They're
I'm
so
still trying to
scared.
get mine for free.
Yeah, I mean, you can lie outdoors naked for a while and you can get enough vitamin D, but it's probably easier just to take a tablet. I'm quite happy. I go outside, but I also take my vitamin D. I check my levels, and it costs $14 a year. A year. So that just gives you an example
Yeah.
of what a complete and utter scam this is.
When you're testing vitamin D levels on patients, what is your goal? Because I know Big Pharma has their reference range, and then I've heard some people say, well, we're looking for like 100, 120, and some are saying 60, 80. What is a good
Yeah, it's a
number?
good question. We don't know exactly. I would say somewhere between 100 and 150.
So
But
everyone would
probably,
say that's toxic. And so you're
yeah,
saying,
but we know it isn't. So
yeah,
they say that because they don't want you to know it works. And so I looked at this recently. And so there have been a few studies looking at high dose vitamin D for cancer. And you know what they call high dose? 2,800 units.
oh boy.
Yeah, so yeah, they do not
Wow.
want you to know that vitamin D is an effective treatment for cancer. They do not want you to know that. So,
So you're
but
saying much higher.
there's a if you really want to be safe, the way I do it, there's something called the Columbra protocol. I don't know if you know it,
Yep.
where you
Yep.
actually follow the PTH level. So if
Yep.
you follow the PTH level, it has to be safe. You cannot overdose on vitamin D. So what I would say, if you're using high dose vitamin D, which is fine, just add a PTH level and it will tell you if you're in the right range.
Sure.
For reference, what are we calling high dose?
So it's really interesting you ask. I take 10,000 a day, which I would consider moderate dose. More recently, for various other reasons, I've increased my dose to 50,000 a day.
50,000.
Yeah.
And you'll do that for how long?
So I plan to do this for about 2 months, and then I'm going to check my vitamin D level, my calcium level, and my PTH level.
Okay. Okay.
Just
Yeah, I
for
usually put
giggles,
20,000, but that's
just
go
for
ahead.
giggles, what can the body generate in a full day of sunshine?
Yeah, so that's a good question.
Because
So
I'm basically outside 8 to 10 hours a day. Today was full sunshine,
yeah,
and that's the next 6 months for me.
yeah, so it's a good question, and it depends upon the time of the day and the latitude you're at. Where you are in terms of how far you are from the equator.
Right.
Um, Obviously, the further you are from the equator, the less you can generate, and you generate most vitamin D related to the angle of the UV rays, usually between 10 o'clock and 2 o'clock in the day. How much that actually translates into orally is a really good question. And I would be guessing, to be
Yep.
honest with you.
That's all I was looking for.
Yes, but there's no question if you did that, you would. So I know somebody who does that, Dr. McCullough in Florida. He had levels close to 100, and he would get on his bicycle almost completely naked every day and drive around for a few hours on his bicycle to generate vitamin D. So I think you can develop, you can develop pretty high levels if you completely expose yourself to ultraviolet radiation.
Skin tone also has something to do with it. So if you've got super light skin and you go out and sit in the sun for 4 hours, and then you've got really dark skin, your melanin is much higher. You're not going to get as much. So
Right.
it's going to vary depending on your
Yes.
ethnicity as well.
And you don't want to burn. The idea is you don't want to be in the sun so long that you burn. Some people can be in the sun, people who have outdoor jobs and they're fine. But other people burn. You don't want to get to the point where it actually burns the skin.
Sure. I've got a question about your, oh, go ahead, Dave.
That's me, is the outdoor work. So at this time of year, it's shorts and shoes. By the time summer rolls around, I'm already brown.
Yeah. The only thing maybe I would suggest is the face is particularly vulnerable to basal cell carcinoma, which is related to radiation. So
Yep.
I wouldn't put sunscreen on your body, but maybe just wear a cap just to protect your nose and your face. That's the only thing I would do.
Yeah. Yeah. I have a question about the mebendazole as well. So I thank you for all your protocols. I love it. I've been reading them and I've been implementing them. You have 200 milligrams mebendazole. It's kind of your main dose. And that's kind of where I start my patients, but if you have someone with glioblastoma, let's say, and I don't know if this is true, this is what I've been taught, is that ivermectin crosses the blood-brain barrier, but not quite as effective as mebendazole. Do you up your mebendazole depending on what cancer it is and where it's located? Or are you kind of like 200 milligrams, that's good, and we're staying there and we just kind of...
Yeah, so that's a good question. So I think all of these drugs act synergistically. We know they act synergistically together. So that's why you don't want to use one drug. When it comes to mebendazole, so for many of these drugs, we're not sure if there's a dose-response relationship. We don't know. So for example, for ivermectin, we don't know what the optimal dose is.
Right.
So what I would say, and so what we've done is say, or start off for ivermectin, like 0.3 or 0.4, and see what happens. If the patient's not doing well, by whatever way you're measuring it, a tumor marker or tumor growths or PET scan, then increase the dose. I mean, it's not rocket science. Yeah. So we don't know what the optimal dose is, and hopefully with time, we'll get more data, because out of all the questions that I want answered, the most important would be, is there a dose response curve with ivermectin? Is there a dose response curve with mebendazole? And the answer is we don't know. But obviously, the higher the dose, the greater the risk of toxicity and side effects, which we want to minimize. And I think, you probably have the maximal benefit at like 0.3 or 0.4. And I think as you increase the dose, the benefits become less obvious. But if a patient has a glio, which is a really bad tumor, I think it makes sense to, you can follow the patient, start off at 0.3 or 0.4. Obviously I would start off at the higher end, and then see what happens. If the patient's not doing well, then increase the dose.
Okay. And I have everyone asking me this, and I've talked to you about this, but methylene blue, that's all over the media. Everyone's talking about it. You have the naysayers, of course, and I'll talk a little bit about what some naysayers are saying about ivermectin. I want to get your take on that. But a lot of people wanting to take methylene blue. I've tried it. I didn't use the red light therapy with it. I'm not sure I felt a whole lot of change or difference, but what's your take on methylene blue?
Yeah, so the answer is we don't know. There's not a lot of data on methylene blue and cancer. And so once we've finished our little chitty chatty, I'm going to go back to AI and ask it again. But when I looked last time, there wasn't a lot of data. But
Yeah.
on the reverse side, since cancer is primarily a metabolic disease, and as Thomas Siegfried has shown, it's a disease of mitochondria. And since methylene blue does improve mitochondrial function and electron transport, it may have a role. So what I would say is that, we've decided what our 5 major drugs are, and if patients are struggling, then there's nothing wrong with adding methylene blue. It's safe. And if patients want to add it, I think it's safe. Now, you want to use it in reasonable doses, because I know there are people that are recommending, completely 1,000 milligram doses, which I think are insane. But
Sure.
if you use I use the 10 or 15 drops a day, which is fine. The
Okay.
only precaution is that you shouldn't be on SSRIs or psychoactive drugs, because it could cause you to become really sick. So
Okay.
you just have to be careful of the drug interactions with methylene blue. The other thing is methylene blue works quite well with photobiomodulation. They kind of act synergistically. So for diseases like brain fog, Alzheimer's, Parkinson's disease, it makes a lot of sense.
Sure. Yeah.
And so, as you say, this is a growing and developing field. We don't know all the answers, but at least you have to keep an open mind. So, who would have thought 3 years ago we would have been suggesting ivermectin to treat cancer? But you know what? There's good science, and I think you just keep an open mind, as we don't know.
Yeah. There's a lot of talk. I'm sure, Dave, you've gotten videos. I probably get 10 or 15 a day of the naysayers, some of which they talk about polysorbate 80 in there, and they talk about
I could name them. Yes, I do get them.
nanotech. I've talked to my compounding pharmacist, who said, no, that's not a thing. But now the new hype is ivermectin causing infertility, which I disagree with.
That's a recycling.
Ongoing.
I've even brought that up. They were dosing rats at 14.5 milligrams per kilogram of body weight and destroying their bodies with it. That's an insane dose, 14.5 milligrams per
Yes.
kilogram.
So this is Michael Yeadon. For some reason,
Yeah.
this is what he's been perpetuating.
Yep.
But just remember, Michael Yeadon doesn't believe that SARS virus exists. So that's how out of space he is. So we've looked at it. It's been used in millions of people and billions of doses. There seem to be a lot of Africans running around Africa. There does not seem to be
quite a few.
There does not seem to be a fertility issue. Almost everyone in Central Africa has been exposed in one way or the other. So we don't think it's a major issue. And
they're taking it prophylactically as well. It's not just a treatment all the time in some cases.
And so I suppose also, if you think of it, if you're dying of cancer, your first thought shouldn't be, oh, I'm going to be infertile. That doesn't seem to be a logical thought process.
Right. Yeah.
Before we lose the time, we did talk about this pre-recording.
Yeah.
the metabolic information, but going further than that to the prophylactic steps in food. You brought up glucose, obviously, and the ketogenic diet, but things people can be thinking about to not wind up in this position, hopefully.
Yeah, so actually you ask an interesting question because, if you read the standard literature, they say about 40% of cancers you can prevent. And the things they talk about are glucose control, insulin resistance, metabolic syndrome, vitamin D, smoking, alcohol. But they don't really talk about pesticides on our food. And so I read a paper like 3 days ago, which shows that the pesticides they spray on our food causes a whole range of cancers.
Yeah.
And so we don't even think about it. You go to the store and you buy food, you don't know what it's being sprayed with. And so many of these pesticides have known carcinogenic properties. So I think it makes a case for organic food. I don't know what else to say. As best you can. The problem is that, of course, it's always the impoverished who get hit the worst because they can't really afford, organic food. But I think what it does mean is that, the new Department of Health and Human Services needs to look very closely at the pesticides that they spray on the crops and what we are ingesting. Because there's certain things like Wi-Fi, and 5G, which, and the air. You have to breathe the air, but you can control the food you eat and what the food is sprayed with. So I think that's another important area that we should look at. We need to get more back to basics. And it's not all about making money, it's about making healthier food.
Yeah.
I would agree with that, and I encourage people to grow their own food as often as possible. I raise most of my own meat, and my diet is very meat heavy, not a lot of vegetables. A little more sugar than I care to admit sometimes. I have a thing for donuts occasionally, but moving away from the food system. But like you said, it's often the impoverished that are sort of stuck in that repeat performance of pulling things off the grocery store shelves because that's what's available.
Yeah.
Right. Well, glyphosate for sure. And then, of course, the elephant in the room, which is the vaccines, not just COVID vaccines, but all vaccines that, I've seen a huge increase in cancer patients with the onset of the COVID vaccine. Not all of them actually received the COVID vaccine. I'd say 80% of my patients who are coming to me with cancer did. So that we talked about this, there's going to be just this huge, I think it's going to be
Tsunami.
higher than deaths. Yeah.
It's going to be a tsunami of cancer. So what's interesting is there was a paper in Lancet looking at the increase in cancers prior to 2020. So there was, I think, something like 16 different cancers were already increasing in young people for reasons that we're not sure. Maybe it has to do with environmental things. But then starting in 21, there's been a massive surge in the risk of cancers. And these are aggressive cancers, early cancers, unusual cancers. And these seem to be very closely linked with the COVID vaccines. And this is where the problem is because, some of the problems with the vaccine, the autoimmune things, manifest kind of early on. We don't know how long these effects, because we know the spike protein hangs around a long time and it may integrate into your DNA. So there was a study out of, I think it was Yale, where they looked at people who had been vaccinated and persistence of the spike protein. So in that study, what they reported, there was a patient who had circulating spike 700 days after the vaccine. But in fact, there was another patient who they excluded because they didn't want to make that even worse, who had circulating spike for 1,400 days. So think about what they said to us, that you get injected in the arm, it stays in the arm, and 2 days it goes away. This poor patient, who is still profoundly vaccine injured, has circulating spike in her blood 1,400 days after the vaccine. She's the longest known person with circulating spike.
You'd
So,
figure at that point her body is making it.
well, her body
It's-
is making it.
Yeah.
That's
Yeah.
the problem. That's the problem, is the only way to explain it is that the RNA has now reverse transcribed into the DNA, and which is kind of what they wanted to do, but they thought the RNA would go away. But now it must be in the DNA, and her body is just making spike protein.
Yeah. And how do you shut that off? I mean, there's spike protein detox protocols. I followed your FLCCC protocol for my COVID patients, and I have to thank you because thousands of patients were saved because of your heroic measures to get that available to people. So thank you so much. And then the spike protein detox protocol that you guys have on there that I follow as well. And I don't know if there's an answer for these patients because it really is. I don't know how long you've got to be on these, and maybe forever, because if you're now
And
making it,
so the problem is it's not very effective. You know, you use nattokinase, which breaks down the extracellular spike protein, but now this is in the cell, in the nucleus. It may
sure.
be impossible. And so what the new NIH needs to do, there are a few things they need to do. But one of the most important things they need to do is they need to study the vaccine injured. They need to study why these people are continuing to shed spike protein. And they need to investigate methods that we can somehow get rid of the spike protein if integrated. It's an absolute medical priority to kind of figure out what's going on. Why is the body continuing to make spike protein?
Yeah.
Well, like you said, reverse transcription, it's part of the body's instructions to itself now.
Yeah, and then if that's what's happening, you know, I'm not a biologist or an immunologist or a nucleologist, but it would have to be some kind of really fancy technique to actually excise the inserted RNA or DNA out of the nucleus. How you would actually do that? But
And it's in all the cells. I mean, it's in every cell.
yes. So that, but you know what we need to look into that.
Yeah. Yeah.
That
Let's talk
probably
a little
gets
bit.
into more editing.
Yeah. It's
Yeah,
crazy.
it's much like video editing. You know how we do that. I don't know, but it's certainly something the NIH should be looking at.
Sure.
I can't think of a more urgent priority than to study the effects, the long-term effects of these vaccines, and why people have circulating spike for so long, and where it's being made, and what we can do.
Yeah.
I
And
think
that's
for starters, we could stop putting it in more people.
Oh, of course. I mean, obviously, the first thing is to stop putting it in.
Yeah,
sure. Sure. Let's talk
I
a
would
little bit
agree.
about
So
that.
that's
Yeah.
research that needs to be done. Oh, so we did bring that up prior to recording as well, that there are now 2 fast-tracked mRNA vaccines. One is the Gates Arcturus bird flu, self-amplifying. And then last week, I saw one that blew my mind. They're fast-tracking an mRNA vaccine for chlamydia.
Yeah. So, you know what? You would imagine with everything that's happened, I mean, it's impossible to deny the fact that there are millions of vaccine injured patients following these mRNA jabs.
Yep.
You can't deny it. So if we were a responsible society, we would at least put this on hold until we have a better idea. There should be a moratorium on messenger RNA vaccines. And honestly, I don't think they have a place at all. It's not like civilization has been deficient in mRNA vaccines for tens of thousands of years, and suddenly we need them for the survival of humanity. We don't need them. And I think we have to be very careful with what we're messing with, because we may not be able to go back again. As we've just spoken, once it gets into your DNA, you may be done for. So we need to stop. We need a moratorium on these vaccines until we know exactly what's happening.
Mhm.
I would agree with that. And I
Yeah.
think we need actual evidence, even in placebo-controlled trials, that I don't see it as being possible, that they're actually useful for something. I
No,
don't
I
think
don't
they
think,
can prove they're not dangerous, but I don't think they can prove they're useful either.
yeah, no, I agree with you. I mean, the whole question of vaccinology, the benefits to humanity is now become an open question. And just an additional layer is the mRNAs. And I think we need to stop using them, and particularly in children. So this move by Kennedy of trying to get the COVID vaccine off the childhood schedule is the right first step to do.
Yep.
We should not be giving these to children.
Right. Well, and we were just talking also earlier about having, doing testing. No vaccine out there right now has been tried against a placebo. So we talked about this. The new vaccines coming out need to be tested, tried before they get it out there, which is going to be a big move. But what about
Yes.
all these other ones that are quite
Yeah, so
dangerous?
that's not quite true, is that the Pfizer mRNA vaccine was a placebo trial. The problem is that Pfizer cheated. They manipulated the data. They fraudulently changed the data. So what's the point in doing a randomized controlled trial where you fraudulently change the data? We know there were more deaths in the Pfizer arm than in the placebo arm. We know that.
Yeah,
So, but they won't talk about it. So what's the point? So
yeah,
the whole system needs to be changed, where the third party people who are overseeing. So if you think about it, Pfizer designs the study so it's positive. They execute the study so it's positive. They collect and manipulate the data so that it's positive. They then write up the paper using ghostwriters so that it's positive. It's completely a bogus system that gives the drug company complete control over their bogus data.
I
sure.
should think third-party trial with no accountability but public. No,
Yes.
I don't want the government in on it either, because they'll do the same thing. They'll lie for money.
Yes.
Right.
So
So
do the
yeah, you
trial,
want
release the data.
you want professional trial companies who that's what they do, who are held accountable. Because if you have Pfizer deciding is this an adverse event or not, it will sway in their benefit. So these should be done, and they should only break the code at the end of the study. So the way that clinical trials are done needs to be completely revamped.
Sure. What about liability? So if they're not going to go back and test these, how about we start making these vaccine companies liable for any kind of vaccine injury? Once that was put in place, the number of childhood vaccines rose exponentially, and no liability, no accountability. That has to change.
Yes, I agree with you 100%. As soon as liability becomes involved and the bottom dollar comes involved, they will be much more cautious and it has to happen. There's no other consumer product that doesn't have some kind of liability. How can you give them liability protection? It'll allow people to make cars that fall apart or explode. So you have to, you can't give them protection. Their products need to be safe as advertised, and they need to be open to litigation if they lie.
Right. we'll see if this happens. Hopefully that's the new push.
Hopefully
So
it's the direction we're moving in. I'm always skeptical that, you know, even if everybody was on the same team moving in the right direction, I'm always skeptical that 4 years is enough to get that kind of work done because of who you're working against. Even working in a vacuum, 4 years is not a lot of time to change the system. But when the system is pushing back against you, 4 years is not but a day.
Yes. No, I agree with you. So a lot has to happen in 4 years, and it could be quickly reversed
Yep.
if the election went the other way in 4 years' time. And this has been going on for 40, 50, 60 years. So there's a lot that needs to be done, that needs to be undone. But I think also there needs to be a lot of, you know, there's been so much propaganda and misinformation perpetuated by the media that don't give you the truth, that we really do need the population to understand what's actually happened.
right.
And I
I
think
think
that's
they're waking up.
I think that's a desperate part of the social media game. And in spite of constantly saying, I don't want to keep doing this, I keep doing it anyway. Like if I can reach one person a week or one person a month that changes their outlook and they start paying attention, then I feel like the time investment is worth it.
Yeah, so I think it's changing. You would imagine the data is so clear cut, you would imagine it would be changing at a much more rapid rate, because it's not subtle.
No.
But there's still people that believe the earth is flat and vaccines are safe and effective.
Yeah. They're lining up,
All cancer is parasites.
and all
Yeah.
cancer is parasite. Yeah.
Yep.
Yeah. Well, we know parasites cause a lot of problems, but not that. Okay. So I know that we got to probably wrap it up, but I'm so grateful, Paul, for you being here. And Dave and I, every time we're so excited that you're coming on and we get to pick your brain and ask you questions. So we definitely want to do this again. I'm excited to have your research and have your documents that I could implement in my practice. And I have I have a patient who has colon cancer, mets to the liver, and just gave me his numbers, and they're almost non-existent. I've got breast cancer patients who had large masses that are no longer palpable. Brain cancer patients whose scans are now negative, and those are the good days. Not everybody responds to this like we want it to, but when you have a win, it just makes everything so much better. So it's your knowledge and your expertise and your time, because you're putting in so much time to then give this to everybody to be able to utilize and use in their practice. So I really,
you know what, I think every win is a win. And, if patients are on chemotherapy, we're not saying stop all chemotherapy, but maybe, think twice about the dosage that is used, to cause complete neutropenia doesn't make a lot of sense.
No.
Many of these repurposed drugs work together with what's called metronomic chemotherapy. So, it would be nice if the oncologists weren't basically their prime interest was making money, because the old adage was, you stopped giving chemo once the patient was in the coffin. And in fact, it seems like that's the truth, is they just want to give chemotherapy. And so if they were more interested in the patient's health and well-being, and they could work together with us, this should be a synergistic, effort. The bottom line is what's best for the patient.
I wonder if they've become, to large degree, and this is giving credit where it might not be due, but desensitized when the outcome is almost always the same.
Yes.
All we're doing is prolonging your life. You're going to die in a couple months.
Yes.
Or you may make it. You may make it another year. We can give you another 6 months, whatever it is, that they're desensitized to the fact that the process that we're undergoing is definitely going to result in failure, and your family is going to be broke.
Yes.
Well, they don't, this is what they're trained to do as well, and they don't know or want to hear anything outside that box. So I have oncologists telling my patients, it doesn't matter what you eat, sugar doesn't increase your risk. They go to their chemotherapy infusion centers and there's cookies and there's donuts and there's just crap for all these patients to eat. And you're right, the high dose chemotherapy, and they'll tell all my patients, you need to be completely off any nutraceuticals. You can't take anything that's going to help boost your immune system. Our job right now is to kill everything. There are some hospitals. I have one patient right now at a hospital in Scottsdale, Envita, and it was fascinating. She's on 4 different chemo drugs. She's got metastatic breast cancer, but it's very, very microscopic doses. They make her fast for 3 hours, and then they give her insulin to drop her glucose to 40. And then they do this very low dose chemotherapy. They rotate it. And so when they give it to her, it's only 10 minutes. And they mix it with sugar. And so these cancer cells who are now starved of sugar and depleted of sugar, then will suck in the chemotherapy mixed with the sugar. And she said, it's very like, no, she feels great. And then the next week they will mix the the chemotherapy with her PRP. We know PRP will travel to the site of inflammation. So again, they make her hypoglycemic, and then they infuse her with this chemo and PRP and a little bit of glucose. And she has no more cancer in her liver. She's also taking ivermectin. They're very active in that. She's taking mebendazole, IV curcumin, hyperbaric, ozone, red light. I mean, everything. And it's amazing. Not everybody gets that result, but the way that she explained it to me, I'm like, that's genius.
Yes.
That's awesome.
Yeah, I think we have to change the traditional oncology paradigm because it's clearly not working.
Yeah. Yeah. Awesome. Well, thank you so much.
Yeah.
Thank you, Dave. You guys, as always, this is so much fun. Let's do this again.
It is always good to see you, Paul. Thank you so much.
Yeah, thank you. So, we have some new documents that are evolving as we understand. So they are available on our website. It used to be FLCCC. It's now Independent Medical Association, IMA, and you can download these documents. They are evolving, but they are available for free.
So what's the name of the second book, Paul?
It has an interesting title, the second edition.
Yeah.
Great. That'll make it really easy for me.
Yeah.
All right. Wonderful.
Awesome. Okay.
Thank you so much again.